It's a great pleasure to welcome you and have you as part of our group today to learn a bit about our work in this area. I'll begin by telling you a bit about who I am and what me and my team do, as well as provide a bit of background on the DSRIP ACO program and its application for ACOs, accountable care organizations in Massachusetts, as well as applications more broadly for organizations engaged in this work across the nation. So my name is Joseph Betancourt. I'm director of the Disparity Solutions Center, and along with my team, the Disparity Solutions Center was founded in 2005. I'm also a senior scientist at the Mongan Institute for Health Policy and director for multicultural education at Mass General, also an associate professor of medicine at Harvard Medical School. The topic of today's discussion will be the work that is going to be unfolding over the course of the next couple of years as part of the Massachusetts DSRIP ACO program, and I'll provide a bit more context about that program in just a moment. By way of background, I'm also a practicing internist. I spend around 30% of my time doing primary care, and what really draws me to this work is my background growing up in a bilingual, bicultural home, being originally from Puerto Rico, and seeing the impact of race, ethnicity, culture, class, and language on health and healthcare. Related to today's discussion, I thought I'd begin by providing some background on the DSRIP program. The Massachusetts Delivery System Reform Incentive Payment Program, DSRIP, is a $1.8 billion 5-year investment program authorized through Massachusetts Health's or Mass Health's Federal 1115 waiver. DSRIP funds support the restructuring of Mass Health's delivery system to promote integrated, coordinated care and hold providers accountable for quality and total cost of care. The DSRIP program funds 3 major initiatives central to transforming Mass Health: accountable care organizations, community partners/community service agencies, and statewide investments. Specifically, DSRIP will support Mass Health's transition to accountable care organizations, including funding to establish community partners to integrate behavioral health, long-term services and supports, and health-related social needs, and funding to support statewide investments to efficiently scale up statewide infrastructure and workforce capacity in support of Mass Health restructuring. For many of you who are listening in from around the country, you know that DSRIP programs are quite common now, with prominent examples in New York and California, and many others being discussed in other states across the nation. The Disparity Solutions Center was selected for its work in equity, disparities, quality, and performance improvement as a technical assistance vendor. Vendors are available in the technical assistance marketplace, and they were competitively selected for their expertise, experience, and skill in providing technical assistance in areas identified by Mass Health's accountable care organizations. If we could go to the next slide, I'll tell you a little bit more about the Disparity Solutions Center, and certainly our hope is to orient you to our work and to give you a better understanding of the types of things that we do and the ways we might assist you, both as a DSRIP ACO here in Massachusetts, as well as an organization who is interested in this area of work across the country. The Disparity Solutions Center, as I mentioned previously, was established in 2005 and is dedicated to developing and implementing strategies to improve quality, eliminate racial and ethnic disparities, and achieve equity in healthcare. We aim to serve as a local, regional, and national change agent by translating existing and ongoing research on strategies to eliminate disparities and achieve equity into policy and practice, developing solutions to improve quality and address disparities, and also by providing education and leadership training to expand the community of skilled individuals dedicated to improving quality and achieving equity. I'll mention that although our roots are in the area of racial and ethnic disparities, we have over the years evolved to cover disparities in a variety of different areas, including disparities by sexual orientation and gender identity, partnerships around disparities in disability, a greater focus on the social determinants of health more recently, and disparities by gender and other socioeconomic class and additional factors. So our scope really can provide organizations with a framework to address disparities or differences in health outcomes or differences in the quality of care received by any particular characteristic. If we go on to the next slide, I'll highlight a bit about what we've done and outline some of our capacities and areas of expertise. I'd like to begin by talking a bit about our work locally and nationally, then move towards some specific talents, those related to strategic planning, leadership and change management, quality measurement, innovations in care delivery, and the development of tools for the field. If we could go to the next slide, please. I'll begin by saying that our work here at Massachusetts General Hospital around the area of disparities began in 2003, shortly after the release of the Institute of Medicine report, Unequal Treatment. After the development of a diversity and disparities committee that was commissioned to develop a strategic plan for our organization, the Disparities Committee in particular that I was able to co-chair with our leadership really focused on three particular areas: how we could more effectively collect demographics of our patients as they registered to our hospital, so data collection around race, ethnicity, highest level of education, as well as language preference, coupled with data that we already had around payer data around gender and the like. How we could then translate that data and stratify that with our quality measures, analyzing our performance in a variety of different areas, and then how we might develop interventions once we found disparities. So our work is long-standing with the strong support of Mass General Hospital, and I'll say that our work at Mass General became our living laboratory, and I'll reference some of those items a little bit later on in our webinar before we get to our question and answer period to give you a sense of ways in which we've tried to innovate locally and then disseminate nationally. The result of our labors over the 10 years from 2003 on to 2013 led to our receiving the AAMC's Learning Health System Challenge Award for efforts to reduce disparities through data collection and quality improvement. And in July 2014, we received the American Hospital Association's inaugural Equity of Care Award for our efforts to improve quality and achieve equity of care for all patients. Suffice it to say that we're very proud of these national recognitions, and I believe that they're proof positive that, number one, we have leadership buy-in to innovate here, and we've tried to do the best we could to quite simply make sure that anybody who enters our doors, no matter who they are or where they're from, receive the best we have to offer. Probably our preeminent activity that I'd like to highlight is our Disparities Leadership Program. And if we could go to the next slide, I'll talk a bit about that. As I mentioned, one of our key areas and goals as the Disparities Solution Center has evolved is to provide education and leadership training to expand the community of individuals dedicated to improving quality and achieving equity. And we chose to do this with the development of the Disparities Leadership Program in 2007. The Disparities Leadership Program is a year-long program where individuals from organizations apply, commit to engage in some process improvement in the area of disparities over the course of the year, get CEO sign-off, and then participate in 2 face-to-face meetings in the beginning and 3/4 of the way through the year, as well as a series of executive education at a distance activities, including technical assistance calls and collaboratives. And our goal is, quite frankly, to develop a cadre of leaders in healthcare that are really equipped with the knowledge of disparities and root causes, the research to date, cutting-edge quality improvement strategies for identifying and addressing disparities, and the leadership skills to implement and transform organizations. We aim to assist individuals and organizations to create a strategic plan to address disparities or advance or improve an ongoing project, and be prepared to meet new standards and regulations from the Joint Commission and CQA for health plans, those as part of healthcare reform. So our Disparities Leadership Program works with individuals from hospitals, health plans, health centers from across the country. We have deep experience working with organizations large and small, public, private, academic, community, urban, rural, again, in the health plan and hospital and community health center space. And I think this provides us with a lot more of just a view from one hospital, Mass General in Massachusetts, but really a more national set of experiences, understanding that these issues move at different paces in different places, and we're able to provide that analysis and framework for local, regional, and national markets. If we go to the next slide, you can see that over the course of the development and evolution of the Disparities Leadership Program in 2007, we have had the good fortune of working with well over 400 individuals from over 180 organizations, including close to 100 hospitals, 44 health plans across 33 states, the District of Columbia, as well as the Commonwealth of Puerto Rico, Canada, and Switzerland. Again, you'll see here that we have a deep experience working in a technical assistance capacity, helping organizations advance this work either by developing a strategic plan or advancing a specific project in this area. If we could go on to the next slide, I want to talk a bit more about the specific efforts we engage in with these organizations and other organizations we work with. I'll begin with our work on strategic planning. That work is led by our Deputy Director, Aswita Tan-McGrory. And if we go to our next slide, we believe strategic planning is absolutely essential to this work. This is where we began at Mass General. This is where we encourage organizations to begin to really develop a framework of strategies that hold people accountable, that are transparent, that are built over time. And the methods we use are those built off of the Luma Institute and IDEO's human-centered design methods. And these methods use critical thinking and problem framing to identify patterns, determine priorities, translate research into actionable insights, and provide successive opportunities for improvement through frequent iteration. A very long way of saying that we have the capacity and have worked with organizations over the years to do an analysis of the type of issues they're facing, their market, their key drivers, institutional and otherwise, an analysis of their leadership, a SWOT analysis of their strengths, weaknesses, opportunities, threats, to really allow them to develop a tailored strategic plan to meet their needs and advance this work. If we go to the next slide, you'll see that we have used this framework locally, particularly here with the Mass General Hospital Executive Committee on Diversity and Inclusion, a multi-year strategic planning initiative that evolved over the last couple of years that is now in the process of being implemented. If we go to the next slide, you'll see how we had the opportunity also as part of our Pediatric Health Equity Collaborative to work with a group of individuals at children's hospitals and or hospitals with a particular focus and interest in the pediatric component of care to develop, for instance, a framework for improving patient and family data collection to identify disparities in pediatrics. So the strategic planning process was used with this Pediatric Health Equity Collaborative led by Aswita Tan-McGrory with an article published here to demonstrate the results of that process and some findings and recommendations for the field. If we go to the next slide, I'm going to turn to another capacity that I'd like to highlight, which is leadership and change management coaching. Over the years, it's become incredibly imperative to us that advancing work in equity and disparities isn't just about data collection and monitoring and measurement and interventions, but change management is an absolutely essential part of the process. This work cannot evolve, despite all the good ideas and good intentions, without an effective change management process. We use this change management process with organizations we work with, particularly through our Disparities Leadership Program. And the change management approach that we've chosen to take, if we go to the next slide, is the Kotter model. This is a model developed by John Kotter focused on leading change that allows organizations to assess where they are in their area of advancement around disparities and equity along these 8 steps that I'll highlight shortly, and think about ways in which they can move forward, understanding that organizationally they may be at a particular step, but for their project they may be at a different step. So we also allow organizations to think about a bit of an index, if you will, of where they are, looking at a variety of different touch points around this aspect of driving change. The Kotter model focuses on 8 areas, including and beginning with number 1, establishing a sense of urgency. Number 2, building a coalition. Number 3, creating a shared vision. Number 4, communicating this vision repeatedly. Number 5, empowering others to act on the vision. Number 6, planning for and creating short-term wins. Number 7, reinforcing change. And number 8, institutionalizing new approaches, with the idea that you might advance and then fall back and need to advance again. You might be in different stages for different projects. Organizationally, you might be in a certain stage. But the net here is that we provide organizations a evidence-based framework to assess where they are and what they need to do to move forward in the change management process. If we go to the next slide, I'll just highlight here that we have had the opportunity to really assess all the organizations that we worked with over the years through our Disparities Leadership Program, and try to determine what separated those who were particularly successful versus those who were perhaps stuck running in place a bit. And what we identified over the course of a multi-year analysis of our organizations was that, in fact, those that engaged in organizational change management, in fact, were able to be more successful. And if you'd like to learn more about that work and our recommendations, particularly for advancing this portfolio of activities through tools of change management, we ask you to please just look up our article in Health Affairs that was released a couple of years back in 2017, actually early 2017, that provides an analysis of this work and the importance of organizational change management to advance this portfolio of activities. Next slide. We have also supported a whole series of collaborations among organizations, understanding that there really is strength in collaborations, that we find solutions together. I've already mentioned the Pediatric Health Equity Collaborative, which is a collaborative of a series of children's hospitals and organizations who are focused on particularly the pediatric population. We've also been able to foster the development of the Minnesota Disparities Leadership Program Alumni Collaborative, as well as the Disparities Leadership Program Mid-Atlantic Alumni Collaborative. What I'd highlight here is that we have a strong series of experiences working with organizations around collaboratives and helping them magnify the work that they're doing together. I'll turn to our next bit of work, an area around quality measurement, where we've really dug deep here, particularly in partnership with our Center for Quality and Safety at Mass General Hospital, leadership of our colleague here, Carrie Kenst, and our capacity to better identify and monitor our performance in the area of equity and disparities. We provide this as a service to many of our organizations in the Disparities Leadership Program as well. And again, here our premier activity, if we go to the next slide, is our annual report on equity and healthcare quality. This report was created in 2007, the first report. It's an annual report that really highlights a whole series of metrics about the care we provide to patients here at Mass General, stratified by personal characteristics, including race, ethnicity, and language. This report, for those of you who are interested, is publicly available on our website. If you just Google the Massachusetts General Hospital Disparity Solution Center, we'll also have our website at the end. You can download the most recent copy of our annual report on equity and healthcare quality to give you a sense of how we work with organizations to get serious about disparities measurement, about equity measurement across the quality sphere. If we go to the next slide, I'll just highlight a couple of items that are part of our annual report, stratifying measures by race, ethnicity, and language to monitor for disparities in quality of care, including who our patients are and where they are seen, so a demographic profile of MGH patients, measurement along a whole series of inpatient and outpatient clinical quality measures, measurement looking at patient experience, as well as department-specific quality measures, in past years highlighting quality measures in obstetrics and gynecology, as well as pediatrics. Here we work with organizations, particularly in our Disparities Leadership Program, to crawl before they walk, before they run. And that was our experience here at Mass General. Our first report was probably in the area of 15 to 20 pages. Our latest report is upwards of 50 pages. And so we can work with organizations to develop legitimate performance measurement tools and partnerships with their quality and safety teams at their institutions. If we go to the next slide, just to give you a sense of the types of things we look at, how effectively we try to bridge our language gaps, providing over 135,000 interpreter visits in 127 languages in fiscal year 2016, and then not ending just with the monitoring and measuring, but just as an example of an intervention, training over 6,000 caregivers at Mass General with an e-learning module focused on issues related to language and patient safety, and that's as of October 2018. When I move forward to our tools from the field, we'll talk a bit about that e-learning module as well as one of our tools. If we could go to the next slide, I'll also highlight our national hospital quality measures, how we're able to display them. In some cases, we're able to display by demographics, including white, black, Hispanic, Asian American, Pacific Islander, Native American, and Alaska Native, and others where we need to roll up numbers to get specific comparisons. You'll see white and other, or English and other by way of language. This is an example of data that we looked at as part of our national hospital quality measures. That was part of our recent report where we found no disparities. We're firm believers in you can't manage what you don't measure, and we will work with organizations to help figure out how they might develop monitoring and measuring tools such as this one tailored to meet their needs. Next slide, please. I'll turn now to what we've learned over the years in our work in innovations in care delivery. So we certainly believe that measuring and monitoring is not enough, that when we find disparities, we need to do something about it. And I'm going to highlight two particular activities that go back now well over 10 years in some of our early work, in which we used our annual report on healthcare quality and equity to highlight or spotlight areas where there are disparities and developed interventions to address them. And I would say that the two interventions I'm going to highlight here are front and center now in the discourse around how to address social determinants and how to improve quality and population health, the deployment of healthcare coaches and healthcare navigators. And if you'll see by the examples I provided here, this is not new work for us. This is work that we engaged in many, many years back, and our lessons learned have helped inform population health strategies both locally and nationally with organizations we've worked with. So the first program I'll highlight here is our culturally competent diabetes disease management program that we did in partnership with Mass General Hospital's Chelsea Health Center, where we identified at our health center back in the mid-2000s that Latino patients were significantly less likely to have their hemoglobin A1C or measure of diabetes tested regularly, and less likely to have their hemoglobin A1C in good control. As a result, we developed and deployed a coach, an individual who we hired from the community, who was bilingual, who we trained in three particular areas: diabetes self-management, motivational interviewing, and cross-cultural communication. That individual, because of our monitoring capacities, was able to get a registry where he could call patients, white, Black, Hispanic, or other, who had their diabetes in poor control, who were seen at the health center, offer his assistance when they came in to see their caregiver or telephonically their diabetes. Our coach would then provide individual coaching to address their specific needs regarding diabetes self-management to help improve their diabetes care, and engage in group education activities working in there. I think we had a technical issue. I'm back on now. Let me step back here and just highlight what I was touching on. I'm not sure when I went off on the audio, probably just a couple of minutes ago. To take a step back, I was just mentioning that, in fact, the work around innovations in care delivery began at the Disparity Solution Center several years back, going back to the early 2000s. Our particular interest was how we could, once we identified disparities, engage in activities to address them. Fundamentally, we began with two approaches to address these issues: the deployment of healthcare coaches and healthcare navigators, and I'll highlight both of these activities in just a moment. Let's begin with our culturally competent diabetes disease management program. This was a program that was developed in the mid-2000s once we identified that our Latino patients at our health center in Chelsea at Mass General Hospital had their hemoglobin A1C, or marker of diabetes, tested less frequently than their white counterparts, and also had their hemoglobin A1C at higher levels, indicating poor diabetes control. We, at that point, in partnership with the Chelsea Healthcare Center, identified an individual from the community, trained that individual in 3 particular areas: diabetes self-management, motivational interviewing, cross-cultural communication. Because we collected data on who of our patients had their diabetes in poor control, that coach could reach out to all those in poor control, including those who are white, black, Latino, or other, and offer a couple things. Number one, outreach to them to help them identify what barriers they might be facing in their attempts to manage their diabetes telephonically or through individual coaching when they came in to visit their caregiver at the health center. The diabetes coach also engaged in group education. And again, this was an individual who was bilingual and trained in diabetes self-management, motivational interviewing, cross-cultural communication, and working directly with those individuals' caregivers. I'll mention that we also linked this program to mental health services, as we identified that over 50% of individuals with diabetes had depression in the previous year, and also tried to link them to more effective, robust efforts around prevention, including mammography, pap smears, and colorectal cancer screening. And if we go to the next slide, you'll see here the results of our initial work. Many of these activities and lessons learned have been deployed and shared locally and nationally as people have built their population health strategies. And again, the topic of healthcare coaches has gained increasing prominence more recently in efforts around population health. We've been doing this for a while. These were some of our early results. When the program began, 37% of our Latino patients compared to 24% of our white patients had their diabetes in poor control. After the deployment of the coach, 2 things happened in just 2 years. The disparity between both groups narrowed and quality improved for both. So decrease in poorly controlled diabetes among both groups demonstrated in 2 years, and a smaller gap between them demonstrated in 2 years. We were fortunate enough to receive the Diabetes Coalition of Massachusetts Program of Excellence Award in 2008 for this work, and been very thankful for all of our partners in these activities. Again, we have experience developing, deploying, managing, and evaluating coaching programs for those who are interested. If we go to our next slide, I'll talk about another activity that we engaged in as a result of our annual report on healthcare quality and equity, where we similarly identified that Latino patients in one of our health centers had their colorectal cancer screening less frequently than their white counterparts. As with all of our programs, coaches, navigators, and others, we engage in focus groups with patients and providers to understand what the barriers are, and then try to deploy an intervention to address them. You'll see here that this program, our Colorectal Cancer Navigator program, began in 2005, in essence, because we had a registry of individuals who hadn't had their colonoscopy on time by guidelines. We developed and deployed a navigator with that registry who could reach out to individuals, identify what the particular challenges were they were facing. Might it be that they simply couldn't get to the health center or hospital? Might they not afford or understand the prep? Might there be other barriers? Might they not have a chaperone? The navigator would then work with the patient, focusing on education, different cultural perspectives, logistical issues, work with the GI suite to get them to colon cancer screening. If we go to our next slide, you'll see the results of our program, which began in 2005, again in partnership with many people here at Mass General Hospital. you'll see that when the program began, about 46% of patients compared, 46% of white patients compared to 36% of Latinos had their colorectal cancer screening colonoscopy on time by guidelines. After the deployment of the Navigator program by 2007, you'll see that colorectal cancer screening rates increased for both groups and the disparity was eliminated. And in 2010, Latinos were actually getting slightly more colon cancer screening via colonoscopy than their white counterparts. Again, I'd highlight that we have experience developing, deploying, and evaluating Navigator programs as part of our portfolio of work, and we're excited about the potential of coaches and navigators going forward to address disparities and achieve equity. We'll move on to some tools for the field. Over the course of our years, we have worked with a series of partners to identify where at the intersection of quality, safety, and equity might the field benefit from guidance. And you'll see here in our next slide that we have worked with a series of partners. I'll call out a couple here. First, our work with the Center for Medicare and Medicaid Services in partnership with NORC at the University of Chicago. We have had a chance to work with CMS to help develop their equity plan for improving quality in Medicare. And we have, among a series of activities we've engaged with them on, developed a compendium of resources to help organizations collect race, ethnicity, and language and disability data. This compendium here contains the latest federal data collection standards, in addition to over 36 what we call real data and disability collection resources. So given that data collection is a foundation, we've worked with CMS to provide guidance to the field on how organizations might do that. If we go to the next slide, as I've mentioned over and over again, data collection is not enough. We've also worked with the American Hospital Association, for example, on a framework for stratifying quality measures by race, ethnicity, and language. This compendium here, in partnership with AHA, provides a 5-step framework for hospitals and care systems to stratify patient data to identify healthcare disparities, including assembling a working group, validating real data, identifying the highest priority metrics for stratification, determining if stratification is possible with selecting metrics, and then stratifying the data. This is another tool in our toolkit that we could work directly with organizations to deploy and execute against. If we go to the next slide, we also have worked a lot at the intersection of quality and safety, built on the research that has identified that minority patients and patients with limited English proficiency are more likely to have medical errors with greater clinical consequences than their white counterparts. We worked in partnership with Apt Associates and the Agency for Healthcare Research and Quality in a 2-year project that included literature search, an analysis of publicly available data, key informant interviews, a town hall, and then developed a guide here that provides hospital leaders with strategies for identifying, reporting, and addressing medical errors that occur in patients with limited English proficiency and those who are culturally diverse. The guide also includes systems-level information on how to develop reporting systems that can successfully capture medical errors for patients with limited English proficiency. This guide is actually coupled with a Team Steps training model. Team Steps is a training tool developed by the Department of Defense that focuses on patient safety within hospitals. We developed a module particularly that focuses on improving team communication to reduce medical errors with patients with limited English proficiency. If we could go to the next slide, I mentioned this a bit earlier. In addition to the guide, in addition to the Team Steps team communications tool, we also developed a tool for individual caregivers, including doctors and nurses, an e-learning set of modules with support from the Macy Foundation, developed in an interprofessional way with colleagues from nursing as well as individuals who are physicians and other caregivers. This project was developed also in collaboration with the MGH Institute for Health Professions, and this e-learning program really focuses on identifying the issue, providing particular guidance on how to use and interpret or how to develop systems, and how to ultimately provide safe, effective care for patients with limited English proficiency. I'll say that we have deployed this program extensively here at Mass General Hospital, with our latest numbers in 2018 demonstrating that we have trained well over 6,000 individuals, caregivers, with this e-learning module that's about 30 minutes or so. I'll say that this e-learning module is also being deployed throughout our partners healthcare system, our parent healthcare system, to help us meet the American Hospital Association's 1, 2, 3, 4 equity pledge, which focuses on organizations signing on to the pledge and committing to diversity in leadership and governance, cross-cultural training for healthcare providers, and identifying and developing a metric around disparities measurement. So this tool is a tool that we've worked on, developed, and deployed that might be helpful to organizations as well. We'll turn to another tool that is particularly timely, a guide that we developed in partnership with the Center for Medicare and Medicaid Services and NORC at the University of Chicago, a guide to reducing disparities in readmissions. Building on the data that has identified that minorities are more likely to be readmitted with conditions such as congestive heart failure, we developed a multi-year project where we did a review of the literature, key informant interviews, town hall, and provided a series of findings and recommendations for the field that include, number one, background on the issue of readmissions, readmission penalties, and their impact on racial ethnic minorities and their impact on cost and quality, an overview of key issues and strategies related to these readmissions for diverse populations, high-level recommendations for addressing readmissions, as well as case studies that illustrate how organizations are addressing avoidable readmissions for vulnerable populations. So this guide, publicly available on our website, is yet another example of the types of tools and skills we can develop in partnership and collaboration with organizations who are interested. If we could go to the next slide, a large part of our work is deploying our guides and bringing them to life through podcasts and webinars. Here's an example of a recent WIHI podcast in partnership with the Institute for Healthcare Improvement that focused on lowering readmissions and reducing disparities. Sweeta Tan-McGrory there from the Disparity Solutions Center on the left, Andrea Tull from the NGH Center for Quality and Safety on the right. This is another publicly available resource. So if we go to the last slide, I'd like to conclude this webinar by highlighting a couple of key points, and then happy to identify any particular areas where people have a desire for more information, engage in some questions. Here's where I'll end. Since the development and founding of the Disparity Solutions Center in 2005, we have developed vast experience in the areas of data collection, monitoring, as well as providing technical assistance to healthcare organizations. We have a series of ready-made, evidence-based guidelines and guides that we've developed over time on improving quality, eliminating disparities, patient safety, preventing readmissions as an example. We have extensive experience in technical assistance, developing learning collaboratives, dissemination and translation are major strengths, and we have strong relationships with a whole series of national, local, and regional partners, as well as hospitals across the nation, partnerships with agencies such as the Center for Medicare and Medicaid Services, Agency for Healthcare Research and Quality, and so our capacity and our view, I think, can allow any organization who's interested in working with us the potential for tailored, customized solutions to advance this portfolio of work. If we go to the last slide, I'd like to thank you so much for your time today. I'm happy to answer questions. For additional information, I'd ask you to please email our Deputy Director, Sweeta Tan-McGrory. You could also go to our website, mghdisparitieSolutions.org. You see us here on Twitter and Facebook if you'd like to follow the work that we do. and learn more about how you might engage with us. I hope this has been helpful to give you a brief orientation of how we could work with DSRIP ACOs, and for those of you who are listening in from across the country, how we might work with you, whether you're in the DSRIP program or you're just interested in advancing this portfolio of work. We look forward to that opportunity. So I'm going to pause now and see if there are any questions before we conclude our webinar. If you have any questions, please feel free to text them in the chat box. We have a chat box here on the webinar. On the right-hand side, you could just enter your question, and we'll go ahead and be glad to respond. As we're considering questions, I'm going to actually raise a couple of frequently asked questions that we receive. I guess one question is, if you're part of the DSRIP program, how might you engage with us? You can certainly reach out to us directly, but there is a TA vendor portal, and that's the appropriate way to learn about us and engage with us more directly. So those would be the appropriate channels for which you could engage us for our services. For those who aren't part of the Massachusetts DSRIP program and are interested in learning more or engaging with us in our work, you could certainly reach out to us directly. We have information about everything that I've highlighted here on our website, as well as information about our Disparities Leadership Program, which provides an opportunity for you to join a growing movement of organizations that are doing this work nationally. All right, well, this concludes our webinar here today on the Disparity Solution Center's technical assistance capacities. Actually, there's one question here that's just popped up. The two innovations you shared were from more than 10 years ago, and innovations that we are familiar with. Do you have any examples of more current innovations? That's an excellent question, and I think what we tried to do early on was innovate locally using Mass General as our lab, and learn as much as we could about coaching and navigator programs, and then pivot in two particular areas. Number one, working as this work was taken up more by other partners within Mass General and within the partners healthcare system, working more with national organizations as part of our Disparities Leadership Program. So we have a whole series of examples that we might provide that are similarly built, and I think some in their nascent stages, developing coaches, developing navigators in areas such as preterm labor, diabetes, heart failure organizations that we've worked with across the country, California, Kentucky, Texas. Our examples, I think, from Mass General were early ones. The pivot is examples that we might be able to share with you from organizations that we worked with over the country. I'll say that we also turned our attention to developing more guidance for the field in a variety of different areas. So the interventions that we focused on more locally here have been more in the quality and safety space, monitoring, training, education, and tried to use our learnings, both local and national, and deploy them nationally, but also inform our local efforts. I hope that answers your question, and certainly if you'd like to learn more about some current examples, please reach out to us and we can link you to several organizations who are doing work in partnership with us across the country. Okay. Well, seeing no other questions, again, I want to thank all those who are listening live, all those who are listening in our archived version of our webinar. Again, we look forward to the opportunity to work and collaborate with you. Feel free to reach out to us, to go onto our website, to sign on, to be part of our listserv, to track our work, to follow us on Twitter and Facebook, and certainly individuals within the DSRIP program here in Massachusetts, please go to the TA vendor portal. You'll see us there listed under performance improvement, and that will provide guidance on how you might engage us. I want to wish everybody a wonderful afternoon, a pleasant weekend, and a wonderful holiday season. Thanks again, and appreciate your time.